So obviously, we're going to see a birth. Yay, exciting, right? How many of you have already seen one in clinicals? Wow, that's a lot. 5 of you?
Yeah, they were busy last week.
Mm-hmm.
That's awesome. And y'all, this is y'all's first week of clinicals, right? This will be y'all's second tomorrow. Wow, that's awesome. Well, great. Then you've already seen this in live action. But I had some tools I wanted to show you, and then we're going to go over just the stages of labor and kind of what we would have experienced before Lucina starts. Because, like, if y'all probably saw in delivery, you know, you saw a patient pushing and things like that. Lucina's not going to grab her legs and push. Okay, I'm going to show you how we would do it and how we would teach our patients to do it. But that baby's just going to come on down when we're ready for it. Okay. Okay. So tools. Did any of you experience a vacuum birth last week? Okay. What did you think about that? It was crazy, right? Yeah. Because it's kind of a rush deal. It's like, okay, we need a vacuum. Let's get it on. It's a last minute kind of thing most of the time. So this is one of our vacuums. This is actually the larger of the two. The other vacuum is a little bit more flush with this. But they take this off, and what they do is it's pressurized, okay? So they're going to pump this up to a certain pressure as they apply it to the baby's head, okay? This is not used to pull the baby's head out, okay? We don't pull the baby. As mom pushes, when she has a contraction, we encourage her to push. We'll go through this with Lucina. We apply this, and as she pushes, we're going to guide, okay? So I just wanted y'all to be able to see that since we have that tool here, okay? We don't have forceps, so I can't show you that, but this is a vacuum. So when we get to that in class, you'll kind of know what I'm talking about. Okay, what did I do with all my fun tools? My other ones. Oh, right here. Okay. So when we talk about an amniotomy, does everybody remember what that is? What is it? Perfect. You rupture the patient's membranes, okay? So that's called an artificial, right? Rupture of membranes. This is an amni hook, if y'all didn't get to see it or if you don't get to see it. See, there's a little teeny hook on there. And that's all it is. It just barely breaks that membrane, okay? Just like if her water had broke. Okay, it's just from the outside and into the inside out. Makes sense? All right. And then this, and I had an IUPC. Look at that.
Did you put it over there by the paper?
Is there?
Or in your stack, like with the vacuum?
Yes. Okay. Will you open that for me? Okay, so those internal fetal monitors we were talking about, okay? An internal monitoring. So this is, this is a fetal scalp electrode, okay, that I kind of touched on. Remember whenever I was talking about how it barely goes into the baby's scalp? Okay, that's what this little teeny needle does. You see how it kind of screws in? And has like a corkscrew. Okay, that's literally all it does. So when they do a vaginal exam, they guide in, okay, and we'll do the same kind of process with an IUPC, but they guide in and then we just turn right underneath the baby's scalp and make sure that we don't have any sutures or anything like that. They make sure it's nice and secure. They don't tug real hard, but make sure it's into the baby's scalp, and then we just pull this out. It's secured, now tracking baby's heart rate, and then we hook it up to our monitors to our strip. Cool? So, when can we not use this? Very good point. I'm not going to put it in the Yes, that's exactly right. You can't use it breech, and when else? Whenever I don't want to expose the baby to something. When they are GBS positive. So, when she has that group beta strep, okay, in her vaginal flora, and that's present, we don't want to expose the baby to that, so we're not going to pierce their scalp. Make sense? Okay. All right, and the other thing I want to show you, and I'll put that back together later. An IUPC, this was that other internal monitor. Does anybody remember what this measures? Perfect, the pressure of the contraction, of what exactly the pressure is inside the uterus. So, it goes in the same way, okay? It goes right past the baby's head, okay? Obviously, they have to be ruptured for either of these monitors. Right in past the baby's head, they're going to secure it, and then they just feed it in. Now, just like an NG tube that y'all have used before or anything else, these have markings on them. Okay, it says stop. So obviously when you're assessing these, you want to make sure that we're still at the same spot. Okay, because if it comes out, you're probably going to see it on the monitor. The contractions, they're not going to look beautiful like that. For those of you who can see, they're going to look kind of funky. Okay, so just wanted y'all to be able to see these tools. All right, did y'all see any of these for those of you who went to the IUPC? Yeah, intrauterine pressure catheter. And then this one is our epidural catheter. So I wanted y'all to see this because nurses are responsible for taking this out of the patient. Some of you may have watched your nurse do that. Once delivery is over, if she had an epidural, this is the catheter, this is the stylet. This doesn't stay in there, okay? Just the plastic catheter. And it's connected tubing to the pump, okay, to the epidural pump that feeds in the anesthetic. We'll go into all those details later. But this is in the patient's back. So when we are done delivering, our epidural's off, she's good in recovery, the patient's stable, we're gonna take this out. So all you have to do is cut your monitor should be off, your pump, okay? Unsecure it from the end, and then you're just gonna have the patient tuck their chin and slowly pull out, okay? What I want you to know is if you ever feel resistance, do not pull hard, okay? This can break, and then it's left in the patient's back. That's a big, big issue, okay? So sometimes when they sit up, obviously their vertebrae can press, okay? So if you need to, just have her kind of round her back, relax your shoulders, just like they would when they place it, okay? But we are responsible for removing them, so that's what I wanted you to say. All right. So what are our how many stages of labor do we have?
3.
4. Good. And this is all fresh, so don't worry if you answer wrong. It's okay. We haven't done this in detail yet. We have 4 stages. How many phases in the first stage? 2. Good. Okay. And what are those?
Yeah, I did.
Good. Good. Latent and then active. So we used to have 3, now we have 2. So what is latent phase? How do I know latent phase? She's not pushing. It's a great point. We're still in that first stage of labor. Okay. How many centimeters are we dilated to? 0 to 5. Very good. Okay. In the latent phase, so we're just now starting. Our contractions are probably mild to moderate, okay, in palpation, and we're going to do that with Lucina. Probably not that consistent. Okay, we might have an irregular pattern right now. Okay, what's our next one? What's our next stage or phase? Active. How many centimeters dilated? 5 to 10. So past 5, so 6 to 10. Very good. So once we're past that stage, then what are we ready for? To start pushing. Okay, so we're ready for our second stage then, right? What do we have to make sure happens before we can just start pushing this baby out? What's important? If this baby's sitting super high, but she's 10 centimeters and she's 100% effaced, what matters? Station of the baby, very good. Okay, so that baby's got to get engaged, okay, into the pelvis before we can really start pushing. Does anybody remember what our station goes to, the numbers?
Oh, yeah. Was it?
Plus 4 on the floor. So for some it's 4 to 4, but for this purpose of this class, -5 to +5. Okay? Those are our stations. Does anybody remember what 0 is? Ischial spines. So not these, but the bottom, underneath the pelvis. So we're even with the ischial spines. All right, so let's start having some fun. How am I on time?
Oh, you're good.
Okay.
You're good.
So I
You
want
still
y'all to
have
all
15
come
minutes.
over here. And we're going to palpate to the abdomen. Come over here.
Everybody come.
Okay. So you can feel the top of the fundus. Okay. You'll see me palpating that. So anytime I'm going to measure, remember how we did that gestational measurement? She can talk to you. That gestational measurement we were doing from symphysis pubis up to the top of the fundus. Okay. Fundus is the top of the uterus, right? What happens at the fundus? Contraction. Perfect. That's the strongest point of the contraction. Okay. So this is how we move that baby down. Okay. So I want y'all to kind of palpate. So you can really feel how that feels, right? Did you already start it?
Uh-huh.
Okay,
I
perfect.
did.
That's fine.
I can't like go. I can't go in the middle. It felt wrong. It felt wrong.
And then you're probably not going to be like, I'm just kidding. No. Okay, so y'all can all kind of feel how the top of that uterus feels. Yes, go right in. So when she has a contraction, this is when we do that, okay, mild, moderate, strong. Okay? I think I feel her breathing more than I feel her having contractions. Okay, so she just finished a contraction. Okay? So these are our contractions, right? I would call this a regular pattern. Can anybody tell me how far apart these are? So they're like 1 to 2 minutes apart. Perfect. They kind of go in between. So we just go for those high points. We don't say like 1 to 2 seconds. 1 to 2 minutes, and they're lasting about how long? It's super tough because these tack boxes are so teeny tiny. So, yeah, they're about.
What's happening?
Oh, Lucina's talking to you. Okay, Lucina, you are having regular contractions. We're going to get ready to deliver this baby soon, okay? So, y'all are funny.
Well, I just wanted them to hear her talk, and I thought, well, that's a good one. I wasn't going to make her scream.
If you're ever talking to people at the patient's bedside, make sure you include the patient. They get super anxious about what's going on, and you're talking around me. Okay, so we've checked Lucina. By the way, she's a 27-year-old prima gravida, which means this is her. Bingo, first baby. Okay, she's 40 weeks. Okay, no complications. This is a perfect patient, and she's blinking. That might be a complication for me. So once we get to completely dilated, and we're at a good station, so I would say 2 to 3 plus. Okay, maybe for a prima gravida whose body hasn't done this before, 3 plus. Okay, station. So when we get to that point, what you're going to have a patient do, not loosen that she can, but you'll have them pull their legs wide back. They'll grab underneath, and what we do is we push with every contraction. Okay. So when she starts, like she started, she's at the middle of her contraction, but when she started it, I would have told her to take a nice deep breath, like she's going underwater, and she's going to hold that and push, okay? And she's going to do that for about 10 seconds, hold that breath. She'll take another one, and then we'll do that 3 times during the contraction. Yes, ma'am?
Why do they hold their breath?
Because, and this is, you're going to hear your nurses say this, and it sounds funny and gross and weird at this point, but it makes sense, okay? The same perennial muscles that patients use to have a bowel movement, they use to push the baby down. Okay, because it's the same muscles down in their perineum. So when they do that, it puts what we call it makes them bear down. Okay, puts pressure down in their bottom. If they're letting out all their air when they're doing that, like it's not as intense, and it's mostly all the tension is up here. It's not down in their bottom like it needs to be. Okay, so that's what we tell them. So she'll do that, hold that for about 10 seconds, and then she'll take another deep breath and she'll do it again. Now, what do we need to be checking this entire time?
Babies, how the babies.
This one. So, what do you not see here that we talked about this morning? Accelerations, okay. But it's okay, because I don't have what? Decelerations. Bingo. You guys are doing great. And I have some pretty good variability, right? Not gorgeous, but it's good. So, whenever I start pushing with this patient, if my baby starts to have decels, it's normal. To have variable decels, okay, right? Because variable means what in our little acronym? Veal, chop. What's the C? What's compressing? Cord compression. So as baby and placenta and cord move down, it's going to get compressed, right? So if we see early decels from head compression or variable decels from cord compression, that's a normal thing, okay? What do we not really want to see? Late decels, because then we need to oxygenate our patient better, okay? So if we do start seeing those, we may have to rest between contractions or put a little oxygen on, okay? Don't think you have to remember all of this. This is just getting you into this.
They're all like, oh gosh, I didn't bring a pen.
This is my daily field, so this is like walking.
I want to push. Can I push?
No, you cannot push yet. Okay. So patients that say that usually don't have an epidural. The reason I say that is because they feel that pressure as the head starts to come down. Let me see where we're at.
I was going to say, you might want to see where she's
Hey,
at.
look. So, y'all see baby? Y'all come around. Y'all all come around here so you can see. I can do it from the side. So, I would say baby's at like +3 to +4 station at this point. Okay? I mean, I don't even have to do a vaginal exam to see that baby's head, right? So this is why she's saying she needs to push. She feels that perineal pressure. Now, even if they have an epidural, I want them to feel that, okay? Because it helps them to know when to push. Because if patients are dead leg and they can't feel a thing, they have no clue what they're doing. They don't know if they're pushing right, they don't know anything, okay? This takes a really long time with Lucina. It doesn't with a regular patient. For those of you who have seen a delivery, it's like once they get to this point, it's way faster, okay? Especially as the head starts coming out, it's really fast. Okay, so fetal strip, look what we had. What did we have?
Oh.
Well, XL, right? So that shows me what? What is veal chop in our A? Oxygenated, okay? Baby is doing good. We are well oxygenated. Now, Lucina's not having to push. She's not having to work, okay? This is not...
This just coming right on out.
Yes. Oh, hey. This is my part, okay? So once you get to where you can kind of see, okay? Because I'm going to be right here in the middle, and I'll kind of squat and do this. So as baby's head starts to come out, okay, so we have descended, right? Engaged in the pelvis, and we're descending out, okay? So this is perfect. So as baby starts to come out, you can see the back of the neck right here, right? This is what we call OP, okay? I'm sorry, OA, because the occiput is to the anterior, okay? If the baby's OP, it's sunny side up, occiput to the posterior, okay? This is how I want this baby to come out. It's the smoothest, best way for delivery, okay? So on your chest, if you're seeing like right ROA, and we'll go over this in class, it just means that the occiput is to the patient's right side, anterior, okay? ROP is right occiput posterior, okay? Makes sense? So this is the best way for this baby to be delivered because that head can kind of, it flexes underneath her pubic bone, and then it's the best way for the baby to come out, okay, as we're pushing, easiest way for mom. If we're looking sunny side up, then we can't really flex and try to come out. It's like a block, okay? But as this baby comes out, you're going to see it kind of turn, and just be prepared. If you're an OB nurse, you will deliver a few babies. It's just the way it goes. Doctors don't always make it. Because it's a spontaneous thing. If this was her third or fourth baby, this would be super fast. I mean, the baby's going to shoot out. Okay. So as this happens, you're going to see the physician put hands on either side. They will be in sterile gloves and gown. At least they should be if they have time to put them on. And they're going to put both hands here, okay? Because babies, just like this baby's slippery, from oil, babies are slippery, okay? There's a lot of amniotic fluid surrounding them. There's vernix on them that makes them sticky. That's that cheesy stuff that protects their skin in utero. So they are slippery. So never, ever, ever try to deliver a baby without a physician at the bottom with the bed broken down, okay? So this bed normally has an attachment that sits here that's the rest of the bed, okay? If your physician is not there yet, don't take that off, okay? Because you don't do this every day, right? So your risk of dropping this baby is pretty high. So at least if baby slipped, we could land right on the bed, okay? So here's head, okay? So this is not birth time. All of baby's not out. Doesn't it turn? It turns on its own.
It turns on its own
Okay.
here in just a second, yeah.
The physician would turn the baby.
See,
Don't
now
do
it's
that.
turning.
Okay, so as that
Not
happens,
yet.
they're going to lower baby down, okay? And then they're going to come that, oh look, we have a little cord on the shoulder, okay? If this is around the neck, we would try to reduce it first, because as you continue to pull, that's just going to get tighter, right? Because it's attached to that placenta that's still in there, okay? So we don't want to pull, but if it's loose enough around the neck to where I can reduce it, we do that, okay? So this one we're going to try to deliver with the baby, okay? Without pulling too much. So what they're going to do is they're going to go down. I'm going to try to reduce that back. I've never had a shoulder cord, thank goodness. And then we get this first shoulder and arm out, okay? And then baby just comes. And most of the time what you're going to hear them say is, look at your baby, look down there. Look, and then we have baby. Okay, do I have your bulb swing? Sorry.
Oh,
Give me that bulb.
yeah,
It's right here.
and is the blanket over there? Oh, sorry, I didn't realize the trash was.
Okay, so we're breathing now, right? We're actually life breathing. So what do we have to do? Here are the airways, where that jump is. So always do mouth first, wide. It's our biggest airway, right? It's bigger than our nostrils. So then we do, and this little thing is slippery, 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 okay? So you're going to see them clear the nostrils, and I'm going to have cottonseed oil all over me. It's good for me. And then what we're going to do is we're going to wait. So we've counted birth time, okay? Now they do delayed cord clamping, okay? So we're letting the rest of that good stuff from mom run to baby. It's really only recommended for 1 to 3 minutes, okay? Beyond that, it actually, we're just now not circulating new blood, okay, because baby's delivered, so that placenta is no longer pulsating, okay? So then it's more about hemolysis, okay? We don't need to get into that deep right now. So what we would do at this point, and these are not clamps, but they're going to act like clamps. You I've never done this stuff. Lucina is like wide-eyed, y'all. So what we're gonna do, and I'm not gonna actually clamp this because I don't know if I should, but you're gonna see them clamp each side. They have a clamp on both sides. Okay, if y'all need to move that way, y'all do something. Clamp both sides, and then usually that's when they say, okay, Dad, you wanna cut the cord? Or whoever the support person is, then they cut this cord and baby's detached, okay? And then, we put baby up on mom, okay? We dry, and stimulate, right? Because not every baby comes out crying and screaming like that, as beautiful as they want to. So we dry them, keep them warm, stimulate, all that wonderful stuff. And after we're clamped, because we put a small little cord clamp on them now to make it shorter. After we are cut and clamped and cut, I guess I should say, and baby's dried, now we can go skin to skin with mom, okay? So then we would transfer, that's where the nursery nurse comes in, and we would transfer Miss Lucina. We would take baby and we put him right here tucked into her down skin to skin. That's what you should see them do. Okay? But once baby's delivered, we have what? And that's our what stage? Third stage. Great. See, y'all are going to have to sit down after today. Okay. Third stage. Do what?
I said not so much.
Yeah, no, right. Okay, so then the cord comes. We don't pull, it automatically comes. So the uterus is still contracting, okay? The body's still working because it knows it's got a placenta to come out, okay? Do I have to guide it, or does it come on its own?
It should come on its own.
Okay,
Just pulling gently, yes.
Okay. So they may give a little bit of tug, but not a lot, because what can happen, you'll learn this in class, I can actually invert the uterus. It goes inside out. Okay, the uterus is not supposed to do that. I've seen it happen. It does happen. Patient immediately hemorrhages. Okay, and their risk of dying are very, very high. Okay, an involuted uterus. I've seen a physician pull so hard that that happened.
Oh.
Okay, and the only way you fix that is by taking your, before going to the operating room, because we automatically prep to go there to try to fix it, is they literally take their fist, push it back in, and it is the most painful and awful thing for a patient. Yeah, but so that's why you don't pull. Okay. We just guide, and I'm going to have to kind of pull up this thing because it's okay. But the body's contracting, it's naturally pushing it down.
You may
we're
have
in
to.
our third stage there.
I was going to say,
Oh, no, I did it. I separated it. It never came. It's not even close to coming. It's still in its little bag. Okay. So, now it's out of the bag, which the patient doesn't really have. Okay. And it's connected. And then what happens is we deliver, and there's a little bucket right here, and this falls in. Okay? So I want y'all to take a look at this. You see all these beautiful, and just ignore the cord's not attached anymore. I apologize, I'll fix that. Okay, so you see these beautiful arteries and veins? Okay, babies are different. Okay, our veins are big, and our arteries are small to baby. Okay? So always remember Ava. Okay? It's a 3-vessel cord, and I'm kind of glad I separated this so you can see. So, babies have a 3-vessel cord. So this is their vein, and these are their 2 arteries. Okay, if you ever forget, just think Ava. Artery, vein, artery. Okay, you'll remember it. Some babies without these, all 3, you'll see why they either have intrauterine growth restriction or don't tolerate labor well because they haven't gotten the oxygen they should have. Okay?
And could they have kidney problems?
Mm-hmm. Yeah. Yeah. But we inspect the placenta both sides. Okay, so this was the side attached to the uterine wall, attached to mom. Okay, and this is baby's side that was attached to the cord. Does that make a lot of sense? Mm-hmm. What happens sometimes are these little patches of tissue sometimes stay in mom, especially if we try to rush the placenta because the doctor's got to hurry them out. Okay, if we do that and some of this is retained, that causes our postpartum hemorrhage. Can cause it. Okay, because we have some retained placenta still in there that the body recognizes it still has, so it's going to keep bleeding, and that uterus isn't going to clam down because we haven't gotten rid of that. Okay, so it can't go back to its normal, firm, small size if it's still got tissue in it. Okay, what do y'all think?
So what would you do if that happened?
Y'all are going to have a postpartum simulation. Okay, we'll talk about it in class. Too,
yeah.
Postpartum, but I
but
want you to see
just
it.
for today.
I want you to see it. Okay, how am I on time?
You got about 2 minutes.
Perfect. What kind of questions do you have?
Does the placenta really look
No, it's
similar to that? What does the placenta really look like?
It's like this, but thicker. But it is like well, I don't have good words to describe it. I would like to think of better. It's like a beefy red,
There you go, Ambrose. A tongue. A big old
I mean, he
tongue.
had to work. So,
It feels like a tongue too.
yeah, it does, but it's like when they describe a beefy red tongue in a patient, you know that that's not a good sign. That's what your blisters looks like. It's giant. It's a lot bigger than this. And I've seen, you'll know like a patient who has smoked. Theirs look very dark, they might have calcifications on them. They're just not healthy placentas. And that's why you see the effects in babies, they're not getting all that good transfer. All right? Does that sound good? Are there any questions? Did this help? Seeing it and talking about it and doing all that? Yes. Okay. Some of y'all don't look so sure. Okay, guys. Well, if y'all don't have any questions, then I think we're good.
Yeah,
We'll let
we're
the
good.
next group in. Okay? I will not see you guys again until you're final. So it's going to be all Skype from here on out. It's like a blackjack.
Yeah.
It's going to be all Skype from here on out, but I will be there for y'all's final. So if you have questions, I will be there for you to ask me. Now, if you have questions about your studies or your exam, raise your hand and ask Ms. Perkins. She can call me or she can talk to somebody else who's taught this class. Okay? But I don't think that you're just on your own. If you have a question, please ask it. Okay? And then to prep you for your HESI, all I want you to know right now is practice questions, practice questions, practice. All right, guys. Rock and roll.
Okay, tell the next group not to come in for about 5 minutes. Okay, we'll come get them.
I just have to do a little thing. Okay, so that was my simulation with the students for my practicum project for education, and it is now complete. Thank you.